And congratulations for this very nice talk about the sacral fractures and the new types of fixation. I will also focus on sacral fractures in my talk because this is one of the fracture types we see more and more in elderly patients today. We have seen, we have heard a lot of lectures this morning about high energy trauma, which means pelvic fractures in adults. You have motor vehicle accidents, motorcycle accidents, falls from green pain or crash traumas, and that is the result. And all these patients are severely injured, and if you look at severely injured patients, a lot of them will have a pelvic trauma. We have heard about classifications, Young-Berger's classification, the ABC of the AO classification. You have heard about distinguishing rotational and vertically unstable lesions. We have heard about temporary stabilization and definitive stabilization, anterior and posterior, using different principles of buttressing, compression, and bridging as the internal fixation fixator we have just heard a moment ago. You have seen these examples of bridging, the symphysis of compression of fracture with a lag screw, of compression of fracture with a sacroiliac screw, and also here the pure dislocation is compressed with this sacroiliac screws. That's a bridging osteosynthesis. And another bridging osteosynthesis you have seen as well in my previous talk. But these are solutions for adults where we have good bone stock. These are people with high energy trauma. We use the ABC classification. We distinguish between provisional and definitive treatment. And we have the classical principles of osteosynthesis that we use in long bones, buttressing, compression, and bridging. But we are now facing an aging population that becomes more and more frequent in our societies. And this brings us new fracture types, new challenges because of the poor bone stock, and not only in the proximal humerus or the distal radius, but also in pelvic trauma. Here you see the median age of our populations that from the World Fact Book 2011, so it's only 2 years ago. Japan has the oldest population in the world, median age of 46.7 years, and Germany, where I work, 46.0, and you see here down the line until Uganda, where the average age is only 15 years old. But so we have new questions. We are facing new questions. Are the pelvic fractures in the elderly similar to those in the adults and in the young patients? Does the ABC classification fit for them? And do we have the same therapeutical principles? To answer these questions, I would like to start again with this patient we have just heard about. It's a suicide jumper patient, 24 years of age. If you look at this, you see perhaps a little bit diastasis of the symphysis pubis, but you cannot very well, let's say, identify a lesion at the posterior pelvic ring. But if you see a three-dimensional reconstruction, you will recognize a spinopelvic dissociation. And what is the definition of that? It's an avulsion of the sacral body of S1 or even S1 and S2 together out of the pelvic ring. The avulsed fragment remains in connection with the lumbar spine, and the deformity can be in flexion of or in extension. Well, if we look now in the literature, and if we look at the larger series of patients with pelvic fractures in the elderly, we will recognize a similar pattern of lesion, the H-type pattern of sacral insufficiency fracture. That's a study of 108 patients published in Spine just a few years ago. And they described these lesions with both vertical and horizontal components of fractures across the sacrum, bilateral or unilateral vertical fractures through the sacral alar regions, medial to the joint and lateral to the neuroforamina. So not transforaminal, isolated horizontal components or variations. And that's the drawing in this publication. You see vertical components, very lateral, not going through the foramina, and then you see horizontal components at the level of S1, between S1 and S2, even at the level of S2, and then incomplete fractures going from one side to the other. All that is possible in the elderly. And here you see it's not an old patient, but he has an old skeleton. Why? Because he got paraplegic 27 years ago, and that's a very poor bone stock he has, because he doesn't use his skeleton anymore. He had already a pertrochanteric fracture on the left, and now he presented to us after a fall from the standing position 6 months before this X-rays. And if you look at his CT scan, you see very, very poor bone stock. And what just I described, or Mr. Lindstrom described, is this insufficiency fracture from the back, from the front to the back, bilaterally. So you see, in this sense, a spinopelvic dissociation because the sacrum and the lumbar spine are dissociated from the pelvic ring due to this insufficiency fracture. And that's what we did. We did a lumbospinal fusion, L4, L5, and then here this very long ilium screw, and we put a bar not behind the sacrum, but through S1, in this corridor of S1, so inside the bone. And we call that a transsacral positioning bar. And here you see the patient 1 year later. The fractures are healed. You see where the transsacral bar was placed is in the body of S1, and the patient was able to stand up again without pain in his pelvis. Now we are here at 65 years of age with a patient that has a pulmonary disease and a long cortisone intake. And look at this pelvis. You recognize immediately that the sacrum is down in the pelvic ring, but is attached, it remains attached to the lumbar spine. And there is as well, if you see in the standing position, left and right, there is a difference. There's also an instability of the symphysis pubis. And if you look at the CT scan of this patient, you recognize complete dissociation of the sacrum out of the pelvic ring because of lateral fractures of the sacrum that went into the sacroiliac joints, and because they were chronic, they looked at, they had this look with nitrogen bubbles inside and with osteolysis at both sides of the sacroiliac joint. So again, to help this patient, we did a very rigid fixation. We opened both joints. We did cancellous bone grafting inside, anterior fixation with 2 plates, a transsacral bar through the body of S1, and a double plate fixation of the symphysis pubis. It was a very thick patient. You can see the fat pad here. And she was able to walk again after 1 year. And you see this is another pattern of insufficiency fracture, not going through the sacrum, but starting very low at the sacroiliac joint, and like a crescent fracture, it goes through both iliac wings, and that's bilaterally, and also in the front there is a bilateral lesion. And that's something you don't see in the ABC classification of pelvic ring fractures in adults. It's something very rare that you have a bilateral transiliac instability in the same patient. And that's the inlet and the outlet view, and again you see this intrusion of the lumbosacral spine together with the sacrum inside the iliac, around the pelvic ring. So what is the anamnesis of these patients? They have severe osteoporosis. Some of them have long-time cortisone intake because of other reasons. There was a previous irradiation of the pelvis because of a malignoma that was resected. Bone harvesting, more and more we see patients that had bone harvested from the dorsal ilium, and they break through this region and have insufficiency fractures there. Long-time immobilization because of other reasons. Also this paraplegic patient is one of this group. Low energy trauma always. Sometimes there is no trauma, memorable, severe pain in the low back. Some of these patients have had MRIs of the spine, but nobody thought about the sacrum or insufficiency fractures of the pelvic ring. Sacroiliac pain, sometimes irradiation in the lower limbs. If you take pelvic overviews only, so conventional X-rays, sometimes you will overlook these lesions because the contrast in the dorsal pelvis is so small that you don't recognize a fracture through the spongiosa anymore. CT scans will help you further. Please use reconstructions, then you recognize fissures, fractures in the lateral sacrum only, not transforaminal, widening sometimes of a joint if it is chronic, nitrogen bubbles as we have seen, sometimes even fracture dislocations also in chronic patients. MRI, if you don't find that, the patient persists with pain, take an MRI, sometimes you will find bone bruise or even incidental fractures in the lateral sacrum as well. So for us, there is a difference between the adults and the elderly patients. Here we talk about an explosion of the pelvic ring due to high energy trauma. Here we talk about an implosion of the pelvic ring because the bone is weaker than the ligaments. You will have fractures of the bony structures, but not ligamental lesions, so it's an implosion. It remains like pieces together, but broken inside. So we need, therefore, we thought we need a specific classification system for this patient population, which makes the distinguish between dorsal insufficiency, ventral insufficiency, combined, or acute and chronic insufficiency. And we were able to publish that. It's published already in Injury 2013 in December, so in the 12th issue. And we distinguish between 4 types. The fragility fracture of the pelvis type 1 is an anterior injury only. It's rather seldom. Mostly if you take a CT scan, you will see a posterior injury as well. The second types are non-displaced posterior injuries. The third type is a displaced but unilateral posterior injury. And the fourth type is a displaced and bilateral posterior injury, as you have seen some examples. So here is the drawing that you know that pubic rami fractures in the front, but without lesion in the back, bilateral, it's a type 1B. Then the types 2 are posterior lesions. You see here fractures through the sacral body and also through the lateral sacrum, but without fractures in the front. There is no lesion in the front. It's only insufficiency in the back. Sacral crush lesions or sacral fractures going through the sacrum from the front to the back are 2B and 2C. And then 3 are transiliac instabilities. You see it starts here, it goes up there with a complete lesion through the ilium. 3B is through the sacroiliac joint. You recognize like a crescent lesion in combination with an anterior lesion, and the 3C is a lesion that goes through the sacrum but is displaced together with an anterior lesion. The most dramatic ones are the bilaterals. We have seen the transiliac instabilities. Then we have the transsacral instabilities, which are likely to be the spinopelvic dissociations, with this 8-type pattern, and then combinations on one side transiliac, on the other side transsacral, are the type 4C lesions. We mean that the therapeutical principles for these lesions also are different from them, from these principles we use for adults. There is no emergency treatment, there is no provisional stabilization. We use these lumbar buttressing in the patients with displaced spinopelvic dissociations. We use more and more the transsacral positioning bar. We use internal fixators, which means angular stable implants, and we also use in some patients the conventional bridging and plating. You have seen this example of our iliolumbar buttressing for a spinopelvic dissociation. This here in combination with a transsacral positioning bar. Here you see the body of S1 from the pure lateral position. You see here the drilling. This is the drill of 2.8 millimeter drill. We focus on the center of this body. So it's inside the bone, it's not behind, and it should avoid any dangerous structure as nerves or vessels. And that's the end of the procedure, only focusing on the back, where you see a bar of 6 millimeter, nuts on both sides, and washers between the nuts and the cortical layer of the dorsal ilium. Here this patient was 85, he had recurring falls at home. We had this diagnosis because he was treated in other hospitals, several hospitals, for his pain, and there was never a CT scan done. This was the result of the CT scan, and only by doing this and pushing these two fragments together, because by turning these nuts, you have a compression on the sacrum. He could survive 3 more years without complaints in the back. The advantages are, this is a less invasive procedure. There is no risk of pulling out of the construct because of the nuts on both sides. There is an interfragmentary compression. By tightening the nuts against the dorsal ilium and using these washers, and the compression force, and that's very important, is independent of the quality of bone within the sacrum. If you use screws in the sacrum, you will have a high risk of cutting out or loosening of your construction. We published 11 cases. These were the first 11 cases. Meanwhile, we have more than 40 in 2012. And you see a follow-up of 14 months, major clinical improvement in 7, moderate improvement in 4 patients. Internal fixators, you have seen this X-ray already. This is an angular stable plate for a transiliac instability. Lag screws are used. Also here, angular stable screws in patients that have low bone stock. There is a higher pulling out force if you use these implants. 71 years, fall from a tree, primary external fixation, secondary use of angular stable screws as well over the ilium as over the symphysis pubis, and here you see the inlet and the outlet view. That's a patient with a type 3A fracture in our own classification. You see a transiliac instability, also pubic instability, and she was treated with a retrograde screw in the front and with an angular screw stable plate in the back, together with 2 lag screws. And here you see the inlet and the outlet fusion. Patient went well after surgery. A similar pattern, 70-year-old Alzheimer's disease, a transforaminal here, and a transiliac here, so a type 3A again, and a very similar osteosynthesis with a plate that is very difficult to lose because of the angular stability of the implants. You should follow these patients over a longer period of time because they can have, let's say, a less dramatic fracture in the beginning, and if you let them walk and they have pain, you look at them back, they can have a more dramatic because of a growing instability in the back. So here you see a patient that was fused between L4 and S1. You see the screws in S1, and she had pain here. You see the fracture in the front because of a fall, and she had only this. You don't see anything in the back, perhaps a little bit a crushed region in the right side again in the back, but this patient was treated conservatively and she was forced to walk, and after 8 weeks she came back, and you see here a bilateral lesion of the front, and if you look, you see this kind of bilateral lesion also in the back through the sacrum, in the lateral mass of the sacrum. So this patient had has now a highly unstable lesion and started with a rather stable lesion, and she had to be treated because of the structure. We could not use a bar, so we used 2 times sacroiliac screws and a long bridging fixation in the front. Pelvic insufficiency fractures are growing in incidence in our hospitals. It's a new pathology for us. They are not comparable with the pelvic disruptions in the adults. For us, the ABC classification does not fit because we do not see any ligamentous injuries. It's just weak bone that is broken. It's an implosion instead of an explosion, and it matches most closely in many cases with spinopelvic dissociations. Emergency treatment is not needed surgically. They are treated differently with iliolumbar buttressing, with transsacral positioning bars, and with internal fixators. But as this is a new pathology, we think that more clinical and especially biomechanical work is needed to shed light on an optimal treatment for these patients, because this remains in discussion. Thank you very much for your attention.